Hello, I'm Miss White, and welcome to Chapter 15. In this chapter, we'll be discussing alterations in diffusion and ventilation. So, as a reminder, ventilation is the process of breathing in and breathing out. But as we all know, we don't have to tell our minds to breathe and we don't have to tell our lungs to breathe. It is an automatic function. So, when we talk about respiratory function, it's important to know that this is a neuronal impulse or signals from the brain that are directed by your lung receptors, which help map your breathing. And this is all controlled by your respiratory center, which is in the medulla and the pons. So, again, your respiratory function is automatic. When we breathe in, this is the process that's called inspiration. So, breathing in or inspiration, this is the process by which the body gathers or obtains oxygen. And it is unidirectional, and we normally move from an area of high pressure to low pressure. Normally, when we inspire, the chest should rise, and you should see the person's chest actually move up in terms of inspiration. Now, when we expire or breathe out, this is the process by which the body removes carbon dioxide out of the body. And that's going to become very important later as we talk about arterial blood gases. So, again, breathing out, or the area where we remove carbon dioxide, is the process by which the body is removing this from the body. And normally, this is a relaxation of the lungs. You should see the chest fall as you expire. And when we have our expiration process, the lungs compress and they eventually increase the pressure inside the airways to help fully expire. So, again, CO2 and the removal of CO2 from the body is going to be especially important, especially when we talk about ABGs, arterial blood gases, and it's very directed by how much carbon dioxide that we're moving out of the body. Okay, so we'll be talking about measurements of ventilation capacity. And when we talk about capacity, it is a measurement of volume. And in terms of volume, we are talking about milliliters. So anytime we're talking about capacities or volumes within the lungs, we do talk about that in terms of milliliters. So now we have tidal volume. Tidal volume is the amount of air exhaled after passive inspiration, or otherwise known as the volume of air going in and out of the lungs at rest. And for an adult, this is approximately 500 milliliters. We have vital capacity, and this is the amount of air that can be moved in and out of the lungs, but this is the maximum amount of air that can be moved in and out of the lungs. We have forced vital capacity, and this is the maximum amount of air that is exhaled during the forced exhalation. And then we have forced expiratory volume in 1 second. So this is similar to your forced vital capacity in terms of exhalation, but there is a time component added now. So we have this, the maximum amount of air that can be expired from the lungs in 1 second. We have the residual volume, and one thing about residual volume is just what it says. When we have a capacity, it's important to note that we don't always get rid of all of the air that are in the lungs. So this amount is actually called the residual volume because it's unlikely that you have gotten rid of all the air out of your lungs. So we have the residual volume. Then we have total lung capacity. And this is the total amount of air in the lungs when they are maximally expanded during inspiration. And total lung capacity is equivalent to your vital capacity and your residual volume. So, again, these are good terms to know and just to understand about lung values, but we're not necessarily being tested on this, but this is good information to know. So next we'll talk about diffusion, and this is the section where we have oxygen and carbon dioxide actually exchanging at the alveolar capillary junction. So what this is saying is that we have the process of ventilation that brings oxygen in the process of exiting CO2, but the area by which it processes is at the alveolar capillary junction. And we have cells that help with diffusion at the alveolar capillary junctions. These cells are called alveolar type 1 and alveolar type 2 cells. Alveolar type 1 cells, they help provide structure with air exchange, whereas alveolar type 2 cells, they help secrete a protein called surfactant. Surfactant is a lipoprotein that helps coat the alveoli, and ultimately they help promote expansion and they help to repel fluids from the lungs. So ultimately, when we deal with surfactant and alveolar type 2 cells, they're the ones that are doing the heavy work to help maintain the integrity of air exchange in the lungs. Now, when we talk about diffusion, there is a level of effectiveness, and effectiveness depends on three different categories. It depends on the pressure, the solubility, and the membranes at which exchange is occurring. So when we discuss the pressure, that is the pressure of the actual particles being exchanged. So that is the pressure of oxygen and carbon dioxide being exchanged at the alveolar capillary junction. We have solubility where carbon dioxide is greater in its solubility than it is with oxygen. So carbon dioxide diffuses more readily than oxygen does, which will become important because CO2 is our main regulator when it comes to arterial blood gases. So a lot of the stability depends on the particle that's readily able to diffuse through the capillary junction. So again, oxygen has a slower rate of diffusion than does CO2, but because CO2 responds greater and is more soluble, it does help with that respiratory exchange when we deal with our arterial blood gases. And again, we'll get into those in a little bit. We have membranes, and generally you have to have an area to which the oxygen and the carbon dioxide must exchange. So the membrane, if it's too thick, you don't have as well of an exchange because they have a farther distance to travel through this membrane. So normally, the thicker the area or the thicker the surface area in the capillary junction, the more unreadily diffusion happens. So again, you want to have like a less thick membrane and you want to have a wider surface area in order to have effective gas exchange. So next we'll talk about diffusion as it relates to the partial pressures. So when we talk about diffusion, we are talking about the process of the oxygen being exchanged and carbon dioxide being exchanged at the alveolar capillary level. And there is a colliding of the oxygen and carbon dioxide particles that creates a force that eventually creates this pressure. So when we look at these pressures, it does tell us how much of each is within the blood and how the body is processing the diffusion of both CO2 and oxygen. So when we look at PaCO2 as indicated on this chart, that is the partial pressure of oxygen in the arterial blood. Um, so it normally has a level of 80 to 100 millimeters per mercury, and it can be influenced by the presence and concentration of oxygen. So you may see some variances in individuals that have oxygen therapy, or maybe even environmentally, people in higher altitudes, you'll see some variations in the partial pressure of oxygen in the arterial blood. And then you may even see variations in individuals that are aging due to their systems not necessarily being as well as they used to be when they were younger. So when we look at PaO2, again, this is the partial pressure of oxygen in the arterial blood versus when we look at PaCO2 or the partial pressure of carbon dioxide, it is the partial pressure measurement of carbon dioxide in the arterial blood. Again, these values are both measured in millimeters per mercury. And you'll normally see these values listed on the arterial blood gas panel or the ABGs. So you'll see a lot of these when we look at ABGs, but the one that we focus on a lot when we're talking about respiratory acidosis versus respiratory alkalosis is the partial pressure of carbon dioxide. So we don't necessarily look at the partial pressure of oxygen as it relates to that, but we definitely look at the partial pressure of carbon dioxide. So this will be the values that we look at when we're looking for normalcy on our arterial blood gases. So again, the partial pressure measurement is 35 to 45 on the partial pressure of carbon dioxide, and that would what we be considering as normal on an ABG panel. So again, when we start looking at ABGs, make sure you're paying attention to the carbon dioxide partial pressure, not the oxygen partial pressure. Do not get those two confused. So we'll talk a little bit about oxygen and carbon dioxide diffusion and transport. You may see a measurement, and it's a very common measurement that we take in the clinical setting. It is a part of our vital signs. It's something called oxygen saturation. So what that does is that it measures the amount of oxyhemoglobin, or the amount of hemoglobin combined or saturated with oxygen. So it tells us a lot about how our blood cells are retaining oxygen. So the normal value of oxygen saturation is somewhere between 95 and 100% per your textbooks. So you want basically all of the oxygen that you're inhaling to be combined with your red blood cells, which is where your hemoglobin cells are functioning at. You want almost all of that to be saturated with oxygen, because that helps with perfusion, which we'll talk a little bit about in a later lecture. But it's a good thing for you to have an oxygen saturation somewhere between 95% to 100%. So once your oxygen saturation occurs, that oxygen continues to diffuse and dissolve in the plasma of the blood, and then that's where you see it carried through your circulatory system throughout the body. But again, oxygen saturation is one of our vital sign measurements, and it helps show us how well a person is carrying the oxygen that they're inhaling. Now, there is a nuance to that. Sometimes you can see some variances with your oxygen saturation. Sometimes you can see a good oxygen saturation somewhere between 95 and 100%, but it's not saturated with oxygen. So in that case, that would technically be an alteration, and it would require an ABG panel to verify where that saturation is coming from. So we use it as an initial measure, but if your patient seems distressed, or if your patient seems like they're not doing well and their oxygen saturation still is showing normalcy, or that area between 95% to 100%, you may want to opt to get an arterial blood gas to see where that saturation is going. Now, we'll talk about carbon dioxide again. Carbon dioxide is a cellular waste product that is released into the bloodstream after the body has used the oxygen, and it is dissolved in the blood's plasma. So it can be diffused in 3 different ways. Again, it's dissolved in the blood's plasma. It can be bound to hemoglobin, or it could be diffused into red blood cells as bicarbonate. But the way carbon dioxide is transported out of the body is through exhalation. So it has to go back through the blood system and essentially back into the lungs, and to be excreted that way through exhalation. This is a really good concept map on the alterations of ventilation and diffusion. So we'll talk a little bit about what this concept map is discussing. So we'll look at the layer that says ventilation, and really the goal of ventilation is to get oxygen needed for cell metabolism. And also the goal of ventilation is to get rid of carbon dioxide to maintain homeostasis, or pH, in the body, and increase optimal cell functioning. So we have alterations when we have a restriction or obstruction of airflow. So ventilation can be altered by simply an obstruction, and we see that with bronchoconstriction, and you'll see that with individuals with an asthma attack. They're having bronchospasms and bronchoconstriction, where they're not able to get air into the lungs the way they need to. So there's an obstruction there. You have suffocation, where you're just completely cutting off the airway to the trachea, uh, which would obstruct air getting into the lungs. So these alterations can cause even more adverse events with an individual if you have an obstruction of ventilation in this way. Another way you can obstruct ventilation or inhibit ventilation is by the inhibition of neural stimulation. So again, we have that respiratory center, the pons, medulla in the pons in the brain, that helps us breathe automatically. We don't have to tell ourselves to breathe. The body does it automatically due to this respiratory system. So, or this respiratory center. So when we have inhibition of that neural stimulation, In such as a case of drug overdose or maybe cervical nerve damage, you inhibit that automatic stimulation, which would then inhibit ventilation. And that's where you'll see other alterations. So either way, if you have an obstruction or if you have an alteration in your brain mechanisms or the neural stimulation of your respiratory system, both of these result in blocked or inhibited airflow, which could then result in hypoxemia, where your blood does not have enough oxygen in it. It can result in hypoxia, where you're now not having enough oxygen in the body to go around. And then you can have that result in hypercapnia, which is the elevation of CO2 in the body. Anytime you have hypercapnia or any of these three, hypoxemia, hypoxia, or hypercapnia, it leads to an acidosis state of the body, respiratory acidosis. And with that respiratory acidosis, you have cell death. So again, this is the mechanism by which ventilation can be altered. Now let's move on to diffusion. And diffusion can be altered a couple of different ways. The goal of diffusion is to have oxygen and carbon dioxide exchange at the alveolar capillary junction. And that exchange is happening where oxygen is coming in to help perfuse the body, and CO2 is leaving the body to help maintain pH and homeostasis. So the alterations of diffusion include the increased thickness of the alveolar capillary junction. So that's a surface area issue. Um, if you don't have enough surface area at the alveolar capillary junction, there's no space for oxygen and carbon dioxide to have an exchange happen. So therefore, you're inhibiting oxygen from coming in and you're preventing CO2, carbon dioxide, from coming out. And some examples of this are emphysema, that's a COPD disease. You have fibrosis, infection, and edema. Another way that you can inhibit diffusion is by having decreased partial pressures and decreased solubility of oxygen and carbon dioxide. So some examples of that would be high altitudes. You see individuals that want to go hiking up a large mountain, such as Mount Everest or those high altitude areas. You see them train for that because their oxygen exchange has been altered with different altitudes. You'll also see decreased solubility in the case of hypothermia and also oxygen deprivation. So if you just simply don't give an individual oxygen that needs it, you can decrease the solubility of oxygen because it's not there. Or even in the case of hypothermia, your body is not moving that blood fast enough because it's cold. It's the body processes has slowed down, preventing that exchange at the alveolar capillary junction from being as efficient. So when all of these things happen, you are blocking the transfer of oxygen and you are blocking the exit of carbon dioxide. Again, this results in hypoxemia, hypoxia, and hypercapnia, which is elevated carbon dioxide levels in the body. Again, these is what leads to an acidotic state of the body, which eventually goes to cell death. So we have ventilation and perfusion that we look at. And ventilation is represented by V, perfusion is represented by Q. And what we talk about with ventilation and perfusion is that you have to have adequate breathing in and breathing out, or inhalation and exhalation, in order to have adequate perfusion. Well, we are just talking about the area of ventilation in this lecture, and impaired ventilation reflects the blocking of airflow in and out of the lungs, which eventually restricts oxygen intake and carbon dioxide removal from the body. And ultimately, this results in a VQ, or ventilation perfusion mismatch. So again, V is for ventilation, Q is for perfusion. When we don't have adequate ventilation, we cannot perfuse the body very well because there's no oxygen to circulate in the body. So again, we'll talk more about this in a later lecture of perfusion, but just know that ventilation is absolutely required in order to have perfusion. When ventilation is impaired, then you ultimately reduce the amount of perfusion that happens in the body. When we have ventilation and perfusion mismatching, it is caused by the compression or the narrowing of the airways. And again, we're just talking about the ventilation portion of this. When we have compression or narrowing of the airways, there's a restriction of oxygen going into the body and the prevention of carbon dioxide from exiting the body. Or it can be caused by that disruption of the neural pathways that stimulate breathing. So, what this results in is two possible scenarios. You can have a lung that is ventilated, so you have air that is in, but it's not perfused. So, again, the organ is trying to perfuse itself. So, you can have oxygen, but because there may be some obstructions or things that are not allowing that oxygen to get to the organ of the lungs, you don't have perfusion, which could cause death of those lung tissues. Or you could have a situation where your lung is perfused. Um, there is blood flow going to the lung, but it's not ventilated because you have a restriction of oxygen getting inside of the body. So again, when we look at ventilation perfusion mismatching, in the case of ventilation, these are the ways that you can prevent adequate perfusion. Now, when we look at perfusion in the clinical setting, we do something called the VQ scan, and that tells us a lot about the ratios and if they're within adequate limits or not. So now we'll look at our alterations in breathing patterns. First, it's important to note that our normal rate in breathing pattern is regular, and the rate should be 12 to 20 breaths per minute. Anything outside of that can be considered an alteration, but some of these alterations do depend on the severity of it. And in this chart, you'll see a variety of breathing patterns that we'll discuss. So when we have eupnea or normal breathing, that's an even rate, rhythm, and depth. And normally this is a response to effective and responsive gas exchange. Then we'll move into tachypnea. Tachypnea is characterized as a rate greater than 24 breaths per minute in adults, but you have a regular rate and depth. It can also be considered rapid and shallow breathing. And part of the reason why the body is doing this is because there's a need to get rid of CO2 in the body, so the rate increases. It can be a response to fever, fear, exercise, and it can also be caused in pneumonia or injury to respiratory centers. So again, tachypnea is a rate generally greater than 24, but you can be tachypnic if you're greater than 20, but it's definitely tachypnea when it's 24 and greater. Next, we have apnea, and apnea is the cessation of breathing for longer than 10 seconds, and it can be intertwined with another breathing pattern. And some of the occurrences for apnea is obstructive sleep, so you're just having different areas that can obstruct your sleep patterns, such as your tongue. It could be the way that you're sleeping. You can have apnea due to premature birth, or you can have a brain injury. So again, apnea can occur by itself, or it can come in tandem with a different alteration in breathing. Now, the next one, we have hyperpnea. So this is also known as Kussmaul's respirations, and there's an increase in rate and depth of breathing. But we want to also call this hyperventilation depending on the condition by which we see these increased rates and depth of breathing. So we have excess carbon dioxide that needs to be released, such as in the case of DKA. When a person is in diabetic ketoacidosis, we often see something called Kussmaul's respirations, and that's that hyperventilation that you see with the process of diabetic ketoacidosis. You can also see hyperpnea with fear, anxiety. You see this with the aspirin overdose and, of course, a brain injury. But the goal is to help blow off excess CO2 that the body does not need. Next, we have bradypnea, and this is a rate that's less than 12, definitely less than 10. We have severe cases of that, and that's where we'll classify this as hypoventilation. And this is slow breathing with regular rate and rhythm and depth. So this can be induced by drugs due to the depression of the respiratory center. It could be caused by increased intracranial pressure or a diabetic coma. So when we have hypoventilation, a lot of individuals with brain injuries and in tandem with hypoventilation, you'll see these patients intubated because their respiratory center is not working very well and it's not telling them to breathe when they're supposed to. So you'll see individuals like this on a ventilator for that reason. We have Cheyne-Stokes, and this is a breathing pattern that happens in a cyclic cycle. So you'll see fast-paced breathing, hyperventilation with periods of apnea. It will wax and wane or crescendo and decrescendo. And again, it occurs in a pattern of apnea. So again, you see a lot of this in neurological patients. The cause could be increased intracranial pressure. You can see damage to the cerebral hemispheres, bilateral damage. It can be drug-induced heart failure, or in the cases of uremia. You have ataxic breathing, which is unpredictable irregularities, a breathing pattern that is unpredictable. And again, you see a lot of these alternative breathing patterns with people with head injuries or traumatic brain injuries. You can see this in meningitis and also encephalopathy. You can have obstructive breathing, which we talked a little bit about earlier in this slide. But this is prolonged and incomplete expiration to overcome increased airway resistance and air trapping. So you can't breathe out as well with obstructive breathing. So apnea is obstructive inhalation, whereas obstructive breathing in this case can be obstruction with exhalation. And you'll see this with choking and things along those lines. So again, this slide is just reiterating what impaired diffusion is. And again, this is the restricted transfer of oxygen or carbon dioxide across the alveolar capillary junction. So there's a prevention of oxygen going in, and there is a prevention from carbon dioxide going out. And again, it does depend on solubility and partial pressure of the oxygen and carbon dioxide. And it also depends on the surface area and thickness of the alveolar capillary junction or membrane. So when you have small surface areas, or if you have thick membranes, this makes it difficult to diffuse oxygen or excrete carbon dioxide. When you have impaired ventilation and diffusion, they both result in hypoxemia, which is decreased oxygen in the arterial blood, which you'll see a decrease in the partial pressure of oxygen. It leads to hypercapnia, which is the increase of carbon dioxide in the venous blood, and you'll see increases in the partial pressure of carbon dioxide on your ABG. And with hypoxia, this is the actual deprivation of oxygen in the cells, and it's noted by your oxygen saturation. And normally it's oxygen saturations of 90% or less. Here are your general clinical manifestations of impaired ventilation and diffusion. You have coughing, mucus production, productive cough is what this is called, or you have hemoptysis, which is blood in your sputum. You have dyspnea or apnea, which is shortness of breath or irregular breathing. You have adventitious lung sounds, which is your rhonchi, rales, crackles, things along those lines. You see individuals use their accessory muscles. So there's a lot of work in breathing. You can see them visibly working to keep their breaths, keep up with their breathing pattern. You'll see chest pain, barrel chest, and you may even see some systemic manifestations such as a fever and increased leukocyte count. So here is your generalized diagnostics for impaired ventilation and diffusion. We'll have pulmonary function tests, which determines those tidal volumes and FV, FV1s, and things along those lines. We'll look at arterial blood gases. We'll look at our pulse oximetry, which is our pulse with just our oxygen saturation. You may see individuals with bronchoscopies, x-rays, CTs, or MRIs. You'll look at sputum cultures and sensitivity tests, and you'll also look at thoracentesis. So these are generalized laboratory and diagnostics for impaired ventilation. And here are our generalized treatments for impaired ventilation and diffusion. So if there's an obstruction, you want to remove them. You want to restore the integrity of the lungs and the chest wall. You want to decrease inflammation of mucus if that's what's causing the obstructions. You want to open and maintain the integrity of the airway. You want to provide supplemental oxygen, and you want to control those infectious processes that are impairing ventilation, breathing in and breathing out. And if you need to, or if this patient's case warrants it, you may want to use mechanical ventilation. These are our clinical models, and feel free to fill out your disease or syndrome cards as we talk through these different syndromes and diseases. We'll be talking about pneumonia, COPD, and COPD has 3 clusters in it. So you have emphysema that falls up under COPD, chronic bronchitis that falls up under COPD, and asthma. We also have cystic fibrosis, and finally acute respiratory distress syndrome. So we'll start with pneumonia. Pneumonia is the inflammation in the lungs caused by the bacteria Streptococcus pneumoniae, or Mycoplasma pneumoniae, or Staphylococcus pneumoniae. Or it can be caused by a fungal infection. When you have pneumonia, you're supposed to be on respiratory droplet precautions because it is a droplet spread. And normally the products of inflammation in the lungs, they cause consolidation. Those are those areas that you see no airspace in the lungs on a chest x-ray. So clinical manifestations include sudden onset of a fever, chills, coughing, sputum production. It can be thick and blood streaked, so you'll see that hemoptysis. It could be yellow. You can have purulent sputum. You can have fatigue. You can have loss of appetite, dyspnea, tachypnea, tachycardia. You may have chest pain that's pleuritic. You may hear crackles in the lungs, diminished breath sounds. You may see tactile fremitus, dull percussion, or respiratory distress in individuals with pneumonia. And as far as your history goes with your diagnostics, make sure that there is a history and physical examination. There's a complete blood count. You may see chest x-rays or CT scans completed, gram stains for the bacteria that's causing the pneumonia. You may see a culture and sensitivity test, which would help determine which type of antibiotics or which type of treatment would best work against the type of bacteria you have or pathogen. You have pulse oximetry and, of course, arterial blood gases. As far as treatment, you want to restore ventilation and perfusion. This individual may need supplemental oxygen until they're able to breathe better on their own. And you want to identify that pathogen and target with appropriate pharmacological methods. Next, we'll talk about COPD. And again, there are 3 different types of COPD diseases and syndromes we'll talk about today. The first one is emphysema. And it is a COPD, chronic obstructive pulmonary disease, that is characterized by irreversible enlargement of the air spaces beyond terminal bronchioles. So you do have that destruction of alveolar walls, your airflow is obstructed, and most oftentimes it is caused by smoking. As far as your clinical manifestations, you have a persistent cough, shortness of breath, wheezing, barrel chest, pursed lip breathing, and you may see elevations in carbon dioxide levels and or hypoxemia or decreased oxygen levels in the blood, according to this individual's ABG. If you look at the chart on the left, I have an example of what a normal adult looks like compared to the barrel chest. You'll notice that the individual with barrel chest, their upper area in the chest is widened, and it's more so widened because of that destruction in the lung area. So you'll see that barrel shape with their chest. And again, this is an irreversible enlargement within their body. Now, the treatment is to maintain optimal lung function. You want to encourage smoking cessation because this is what causes emphysema. You want to do pharmacological therapy, and the individual may receive a lung volume reduction or a transplant because, again, those lungs have expanded to a point where you have this expansion of the chest. So you may see individuals get a lung transplant as a result of that. Next, we'll talk about chronic bronchitis as it relates to chronic obstructive pulmonary diseases. So this is the second one that we'll talk about today. And it is the result of chronic inflammation and edema of the airways. You have the increase of bronchial mucus glands and the smooth muscles in the lungs. You have cilia destruction, you have squamous cell metaplasia, they're dying off, or you have bronchial wall thickening and fibrosis development. So COPD, chronic bronchitis, is more so an issue of inflammation and edema in your airways. You'll normally see a persistent productive cough that lasts greater than or equal to 3 months for greater than or equal to 2 consecutive years. So that cough is productive. You have purulent sputum, you have shortness of breath, those adventitious lung sounds, and you'll also see individuals on their ABG with hypoxemia or hypercapnia, and you may even see cyanosis in individuals like this. As far as their diagnostic criteria, you have to have a H&P, history and physical examination. You want to look at their arterial blood gases, pulmonary function test, pulse oximetry, and you also want to analyze their sputum. So this one, you still want to encourage smoking cessation, but just because you smoke doesn't mean that you automatically get chronic bronchitis, but it does not help. So you want to stop smoking. You want to encourage pulmonary rehabilitation. Pharmacological therapy is bronchodilators or steroids. You may see mucolytic agents as well. And you also want to provide individuals with this with supplemental oxygen. The next COPD disease we'll talk about is asthma, and it's characterized by intermittent or persistent airway obstruction due to bronchial hyperresponsiveness, chronic inflammation, bronchoconstriction, or excess mucus production. Signs and symptoms or clinical manifestations include wheezing, tachypnea, shortness of breath, dyspnea, coughing, chest tightness, excessive sputum production, and anxiety. His diagnostic criteria includes your pulmonary function test, arterial blood gases, pulse oximetry, and your chest x-ray. As far as treatment, you want to encourage spirometry, which helps work those lungs better. You want to monitor your lung function, control environmental triggers that could cause inflammation and potential asthma attacks, and that could potentially be dandruff or pollen or things that would not normally be considered triggering that triggers the asthma attacks. Normally you have pharmacologic therapies such as bronchodilators. You may see steroid use in individuals with asthma, things along those lines. And you want to have family and patient education and encourage them to have an action plan should someone have an asthma exacerbation. So let's talk a little bit about what happens at the cellular level in an asthma attack. So again, you have that allergen, that's pollen or pet dandruff or, just flowers in general, something that triggers the inflammatory response. And as a reminder, your inflammatory response includes your mast cells. Mast cells release histamine, leukotrienes, interleukins, and prostaglandins. And then it has that robust inflammatory response. That results in the release of cytokines, interleukins, and other inflammatory mediators. So again, your inflammatory response is mounting and mounting against this allergen that is causing this asthma attack. Eventually, your airway becomes inflamed. You see swelling and you see epithelial injury, and ultimately you see impaired mucociliary function in the airways. So with that, you have airflow limitation. You can have bronchospasms as a result of mast cells starting this inflammatory response. But with that bronchospasm, you have increased airway responsiveness. So that's the part that they're talking about over responsiveness with the airway, which is where you hear that wheezing and people struggling to breathe when they have an asthma attack. On the right side here of this chart, you'll see a bronchiole that doesn't have any issues, and then you see the bronchiole that is obstructed, and that's where that bronchospasm is trying to get rid of that mucousy thickening that's located within the bronchiole. Here we'll talk about cystic fibrosis, and the pathophysiology is that it is an autosomal recessive disorder, and it is a disorder that affects your electrolytes and water. So it's definitely a fluid electrolyte issue as well. But it results from the genetic mutation of the CF gene. So it affects certain epithelial cells, particularly with your respiratory tract, your digestive and reproductive tracts. In the lungs, it is mostly associated with mucus plugging, inflammation, infection, and it can affect other body systems. But ultimately, respiratory failure is the most common cause of death with individuals with cystic fibrosis. So, as far as your clinical manifestations, it depends on which area that is affected the most. But more commonly, we talk about this with respiratory effects. So, again, you see respiratory infections, you see chronic cough, purulent sputum, tachypnea, wheezing, crackles, hemoptysis, shortness of breath on exertion, chest pain, respiratory distress. If we're talking about the GI, we have intestinal obstructions. You may see large greasy stools, abdominal pain, and as far as the effects on the reproductive system, you do see infertility. So one of the most important diagnostic tests for cystic fibrosis is the sweat test. And this is where that fluid and electrolyte concept comes into play. When they look at your sweat test, they're seeing how much sodium you're losing as a result. And more oftentimes than not, when you're sweating and you have cystic fibrosis, it's a very salty, heavy content. They also do genetic testing to see if there is a mutation in that CF gene. They also do chest x-rays and stool analyses. As far as your treatment, you get chest physiotherapy. You do have pharmacological treatments. As far as your GI, you want to encourage optimal nutrition and pancreatic enzymes in individuals with cystic fibrosis. So the main point here is to understand that this is a fluid and electrolyte issue, particularly with sodium. And the most telltale sign with the cystic fibrosis is the sweat test. Next, we'll talk about acute respiratory distress syndrome, also known as ARDS. And this is a very severe acute inflammation of the lungs. It can result in pulmonary edema without evidence of fluid overload, or it can impair cardiac function. More oftentimes, it's a progression from lung injury into respiratory distress within 24 to 48 hours. A lot of these individuals do have to be intubated because of how severe the effects are. As far as your clinical manifestations, you have tachypnea, dyspnea, retractions, crackles due to fluid accumulation, restlessness, and anxiety. As far as your diagnostics, you want to have a history and physical examination, but it's also the presence of symptoms. Acute respiratory distress syndrome is a medical emergency, and this is an airway issue. You have to protect that individual's airways. So you may not necessarily have time to get a full assessment in, but if you see that an individual is exhibiting those clinical manifestations, especially the shortness of breath, retractions, and anxiety, restlessness, it could be a sign of impending doom with the individual. So you want to make sure they get their airway protected as soon as possible. You'll have laboratory studies on an individual with ARDS. You have arterial blood gases that are done, blood cultures to detect if it was caused by a bacterium. And of course, you want to have imaging studies on your chest, like CT chest, chest x-rays, things along those lines. As far as treatment, you want to remove the causative factors. You want to give oxygen immediately and 100% at that if they're in acute distress. And eventually they will be intubated until their respiratory status stabilizes. So let's talk a little bit more about ARDS in detail. So we'll go through the 6 different phases of acute respiratory distress syndrome. So again, it is based off of the different triggers. And when we have triggers of ARDS, it produces inflammation. Those triggers include excessive smoke, toxic chemicals, lung infections, aspiration, direct lung trauma, and anaphylaxis. So as we see in the chart, we have phase 1, and that injury, regardless of which trigger it is, there is direct injury to the blood flow to the lungs. So when we have that happen, platelets are aggregating and they release histamine, which is one of our inflammatory cells to help with the inflammation response. So we have histamine, serotonin, and bradykinins. Then we move into phase 2, where histamine further inflames the lung area, and especially at the alveolar, alveolar capillary membrane. That capillary permeability is opening up as it does in the inflammation response, and fluids get into that space. So let's think about that. Normally in the inflammatory response, when there's direct injury, you have the inflammatory response to help push inflammatory mediators to the site of injury to help promote healing. But in the case of acute respiratory distress syndrome, not only does the healing attempt to happen, but there's a lot of fluid shift into that space, and that actually causes a bad thing for the lungs. So let's move to phase 3. So as we move into phase 3, the permeability is continuing to increase, and all this fluid is getting into this alveolar area. So there are proteins, fluids, things that cause osmotic pressure to increase, which ultimately results in pulmonary edema. So we have swelling and damage to the alveolar type 2 cells, particularly the ones that help produce surfactant. As we talked about in previous lectures, alveolar type 2 cells help with lung expansion, and it also helps with decreasing fluid accumulation in the lungs. So those cells are also damaged due to pulmonary edema. So once we have this increase in permeability and these fluids are leaking out and getting into this area, we have decreased blood flow to the alveoli, and that impacts the cell's ability to expand more, as what surfactant helps the lungs to do. So the alveoli eventually collapse, and that eventually stops gas exchange because the lungs don't have the surfactant that it needs in order to expand and take in air. So we see damage at phase 4. Once we have that damage, we don't see sufficient oxygen getting to the alveolar capillary junction. So there is a underproduction or of oxygen being able to get inside, and then we have an increase in CO2. It's not getting out because of this fluid. So again, we don't have that alveolar capillary exchange anymore. Oxygen is prevented from getting inside of the alveoli, and CO2 cannot get out of the alveolus. So now perfusion is affected as a result of this fluid accumulation in the lungs. And again, this is where we have pulmonary edema worsening. So we see something called atelectasis, and this is where we see the collapse of the lobe of a lung or wherever the area is affected. And again, those air sacs, the alveoli, they have deflated, so we don't have that area of expansion that we need in order for oxygen and CO2 exchange to occur. Now, with that worsening pulmonary edema, that inflammation leads to fibrosis, and unfortunately, gas exchange is further prevented in the alveoli. So now we have this progressive and extremely dangerous situation, because now we're not getting oxygen to not only the lungs but to other parts of the body, because there's no gas exchange within the alveolar capillary area. So this is where mechanical ventilation becomes important, because the body is not perfusing itself, it needs help. So that's one of the ways that we use mechanical ventilation to help individuals breathe and be able to heal enough in order for them to start breathing again. Now, of course, this would be paired with different types of medications to help pull the fluids off of the individual. And you may even see some cardiac medications to help the heart pump better, because once you see a decrease in ventilation, perfusion may also be affected, which can also cause strain on the heart. So that would be a little bit more detailed than for the necessary requirements for this particular class, but just understand that when acute respiratory distress syndrome happens, the body truly is in distress, and if it's not ventilated immediately, then you see lack of perfusion, which causes the other issues within the body. So that concludes our chapter. Make sure you review the textbook. Make sure you read up on the concepts that you did not understand. Make sure you complete your guided learning questions and system disorder cards. Review your case studies and activities. Make sure that you look at the pathophysiology, clinical manifestations, diagnostics, treatments, and applications for the clinical models that we have discussed. And make sure you check your understanding. You can quiz yourself and quiz others and try to answer those questions in the back of the textbook. If you have any questions, I'm more than happy to assist. Please reach out to me and I'll be more than happy to clarify. Thank you, and I'll see you in the next lecture.